So this is a reminder for those that have a question that are not in the room. There's ways to submit a question anytime during the session, so look for this link to the social Q&A in this little app here, in the mobile app, and you can post your questions, and we'll try to address them. I think we're going to have a really interesting session here. This is our first Geohealth Union session, and we're really excited about bringing together the two worlds of geoscientists and health scientists to apply our science together to address important public health issues. Today's focus is really important public health issues because they're about disasters and emerging threats. And how do we bring our science together in order to address these situations, which are clearly increasing throughout the world and really challenging at the same time. And there is no real home, both in the United States and globally, in a way that our research is funded or coordinated. So we've been doing it together in different ways and trying to come together to create forums and platforms for this to take shape and for us to really get out there and to overcome challenges, to move forward with our communities, and to be able to advance science so we can be better prepared, so we can respond and we can recover to these situations. I'm not sure if our first speaker has arrived yet. No. So in lieu of not having our first speaker at this time, we're going to probably take any opportunities to have some additional discussion, but I wanted to mention a little bit too about the Geohealth section. So the Geohealth section is a new AGU section, so that for those people that are watching or in the room are interested in this, we're looking for people to join us in our mission to bring this transdisciplinary or convergent science together. And we're also looking for people that want to help us lead the section. So if you're interested in participating and beyond just becoming a section member, there's opportunities to be in a leadership role. So please join us for that and let us know that about your interest. We have a newsletter, and there's also a new AGU Geohealth journal, and that is now available and has been out actually for about a year. So if you have submissions or interest in this space, please take a look at that. I guess we're kind of in this mode, waiting for the first speaker who's not here. So there's a question over here from the audience. If you could use the microphone, and I'll urge anybody that has questions at this point in time. And again, welcome everybody. This is Thursday morning, and I realize it's early, and I have these really bright lights in my eyes, so if you see me squinting a little bit, I apologize, but this is the way we set up the room this morning. So please.
Yes, Aubrey, so since you're looking for some filler material, I'll make a quick
Yeah,
comment.
I think so.
So my name is Lex van Geen. I'm a geochemist at Lamont Doherty. And the comment I wanted to make is the following. So I've been working with public health scientists for almost 2 decades on the Superfund program in countries like Bangladesh. And I think the one lesson I've learned from that is relevant to this session. Public health scientists, at least in my experience, look at the relationship between a biomarker of exposure, say lead in blood or arsenic in urine, and the relation between that and health effects. And that is really their specialty. More often than not, I've noticed that why a biomarker has reached a certain level isn't really, isn't the main thing they are concerned about. And it's often not a simple problem. And I think that's where we geoscientists can make a contribution and help establish the relationship between what people do, what soil they ingest, what water they drink, and why the biomarker gets to a certain level. And so that's why I was excited to see this new activity within AGU. Thanks.
Yes, thanks, Lex. And he was really commenting about the importance of differing perspectives and geoscientist perspectives to what we try to study from a human health side as well. So a lot of human health scientists, as Lex mentioned, are focused on markers of exposure that we can measure in blood or urine, or now looking even with DNA and what's called DNA methylation, and moving more into the area of epigenetics. And we're talking a bit about this issue of gene-environment interactions is one component of this. And while the health community a lot has been focused on the gene, it's really the expression of disease and health in many ways is that full interaction that we need to be focused upon. And how important it is for the geoscientists and exposure scientists and toxicologists among us and people studying atmospheric sciences and hydrology, thinking about what do we understand about the exposures broadly speaking, those pathways of exposures to people, the complexity of those interactions, and what it really means in terms of the physiology of our response. And not just in human health too, as well as our biota and animal sciences as well. And it's really important to be thinking about this broadly. We're seeing, I think the World Health Organization puts about environmental contributions to disease at least 25%. So the significance in order to be able to create improved health among our populations is profound in this space, right? I mean, you can't change your genes, as my director at the National Institute of Environmental Sciences says, but you can change your environment, and we can do things to protect ourselves. When it comes to situations like this that we're talking about here with disasters, the criticality of us being able to bring our science to the situation, and for those that are watching or here in the audience, you think about it from, a lot of times we're in our own world. We're doing our particular research or our kind of our little pipe stove of what we're kind of focusing on. But I want you to think broadly about how can you contribute? What partnerships do you need to make with others in order to translate your work to allow it to take shape and to affect communities in a positive way? And it's never more so when we have a really urgent situation. So in many ways, we're thinking about some of these things in what we do, but when you have a disaster, you have to bring it, and you have to bring it fast. And it's the most challenging of situations, because if you don't have relationships beforehand in order to begin to do this work, it's very hard to do under the conditions of an emergency, is trying to figure out who do I connect with, how do I tell them, oh, I do exposure research on this, and it's really important, and I can help with this situation. But when something happens, it's very hard. So I want folks to think about who are your partners, and who can you connect with from the health community and others, from public health, from other officials, in ways that they understand what you do, in ways that you can help to provide information. And not all of us are ready to be in the field for this, but we always are looking for folks to help us with our science to help address some of these issues and situations as we go forward. So, to give an example, we worked on the Gulf oil spill, and that was a really complex and large-scale oil spill in the United States in 2010, affecting essentially the coastlines of 4 states. NIH, we put together a research response trying to look at workers. There was over 130,000 workers involved in that situation, trying to do cleanup. And these workers were really people that had been affected in many ways. We had some professional workers that were out there working on the oil, but we also had people that were cleaning up beaches. We had fishermen that were, instead of fishing now, were actually out there helping skim water and clean up areas. So you had a lot of people from a lot of different perspectives. You had communities who ate seafood and shellfish that were subsistence living on that food, and were seriously affected and certainly concerned for themselves and their families. So how do we address those situations, and think about the complexity and all the different work. So oil was being burnt out in the water. They were using high levels of dispersant chemicals to treat the water, as well as the oil showing up on beaches across the country. And despite that, and you think, wow, here's a situation, oil spills, and we hear about these relatively frequently, there was almost no human health studies. There were only a handful of human health studies. So when people started to ask, well, what should we be worried about? What are the health effects to myself, my family, my community with respect to this situation? We had very little to tell them. And so and this is one of the few situations in some respects that we tried to apply a really kind of convergent science with partners from academia, partners from federal agencies and others, and public health authorities to try to begin to pull it together and look at this. So we funded communities and academic and non-governmental organizations to try to identify issues of concern to themselves and their communities that could be then funded and researched. Simultaneously, we did, in partnership with other agencies, a large intramural study of the workers that were working on various aspects of the spill. And this continues to go on, so we're beginning to get some information to move forward. I think we're getting ready to start.
Yeah, we're going to give you the hook up right now.
That's it?
So, suggestion is on because she's usually short, she has no slides. So
Okay.
she can go now and then we'll be like 5 minutes behind.
Okay. So I'm going to welcome our first speaker, Dr. Chris Ebi, the Roman Haas Endowed Professorship in Public Health Sciences and Professor of Global Health and Environmental and Occupational Health Sciences at the University of Washington. And welcome, Chris, and glad you were able to make it. So we look forward to hearing from you. Please.
Great. And obviously a total dork, I've been sitting over in the hotel where all the other Geohealth sessions have been held. It's only after somebody started talking about earthquakes, I went, I don't think I'm in the right room. I really apologize. I've been here for quite a long time, but completely in the wrong place. I don't have any slides, and I really only wanted to make a few comments anyway. I wasn't going to take the full time. And the main points I wanted to make are covered in the abstract, that there is an enormous investment, a very useful investment, in obtaining a lot more environmental information. So we now have terabytes and terabytes of information. But that investment has not been matched with how can we really use that information to improve population health. So you see a real mismatch between these investments. And there's an enormous opportunity to capitalize on these investments if we can get further investments into the health side so that we can use this information with some caveats. And a couple of the caveats I wanted to make is there's been quite a focus on using environmental information, for example, to set thresholds. But there has been relatively limited investment in how to integrate those forecasts with what we understand in population health from conducting risk assessments and in risk communication. Scott Sheridan several years ago had a paper where he sent out students within 1 week after a heat wave to 4 cities in the US. Non-random sample, adults over the age of 65, and asked them a series of questions. The answers were more than 90% knew there was a heat wave. More than 75% listed at least one thing people at higher risk should do differently. And well less than 50% did anything differently. They don't see themselves at risk. They don't really understand the information from the broadcast meteorologist in a way that affects them. And so thinking about how to really make that connection so that people understand that they're at risk. Tens of thousands of people around the world die every year in heat waves. Every heat wave death is potentially preventable. We don't need further information on thresholds. We need a lot better information communicated to people. And so when you look at the kind of information that we've generated in the environmental health side, we've got hundreds of publications identifying particularly vulnerable populations, particularly vulnerable regions. I mentioned adults over the age of 65 are particularly at risk for heat. And yet all of these investments results in my local broadcast meteorologist standing up and telling me it's hot, which I kind of guessed, right? It's nice to know how hot it's going to be, and there's other things that are really nice to know, but there's lots of opportunities to think about, for example, particularly for heat, some kind of tiered system. We know that adults over the age of 65, people with chronic diseases, people who take certain medications, and these medications are quite common, like beta blockers and many of the psychotropic drugs, put people at much higher risk. But why do we have the same threshold for everybody? Why are we not setting tiered thresholds so that the broadcast meteorologist can stand up with the appropriate information from the local health department a couple of days early and say, it's starting to get hot, a heat wave is coming, we've got greater skill, and these groups need to start paying attention now. So we really can start partnering better and using more information so that we can ensure that we have appropriate behavioral change. As I mentioned with a story from Scott Sheridan's publication, there's a lot more that needs to be done to understand that behavioral change. If anyone understands how difficult it is to implement effective behavioral change, it's population health. We know from tobacco, we know from obesity, on and on and on, of how difficult it is to really understand what motivates change. And it's an area where investment could make such a difference, particularly as our climate continues to change. With that said, the investments in early warning systems, again, I'll just focus on heat because it's slightly easier, but it's also true for other early warning systems, is that the early warning systems are now established based on current exposure-response relationships, current seasonal relationships. And there's very limited effort in heat wave early warning systems to acknowledge the fact our climate is changing. They typically start mid-May, they typically end in mid-September. A couple of years ago, there was a big heat wave in London at the end of September, after the heat wave early warning system was turned off. In May of this year, there was heat waves in Sweden, and I read somewhere that the return period of those heat waves was 3 in 1 million years. It's kind of hard to wrap your head around 3 in 1 million years, but the system, it was before the system was turned on. We know these changes are going on, and yet the heat wave early warning systems are fairly static. It's something that people are implementing, ticking the box, we're done. But we're not done. The climate continues to change. We know the intensity is changing. We know duration of heat waves are changing. We haven't spent very much time trying to figure out what do you do, for example, in the big European heat wave in 2003 that went on for more than 2 weeks. And there was challenges. The only heat wave early warning system at the time was in Portugal. And they had a really hard time with their media because the media said, well, it's a heat wave. It's been going on for a while. It's not news. We're a news organization. And how do you make something news that continues to go on? And how do you help get that out in messages that are really effective? And then, of course, the climate's going to continue to change, so we're going to continue to see changes over time. And to start thinking more creatively about how to bring those changes over time into our early warning systems. In addition, we know that the range of possible futures is quite broad, and that is not being taken into account. I showed in Geohealth session a couple days ago, there's a paper that came from Sonia Seneviratne on what does a 1.5 world look like. And it's really stunning that when you look out, we'll hit 1.5 between 2030 and 2050, so we're just talking a couple decades. If we're in the lower quartile of the response of the climate system, then the change in the United States from today will be pretty minor. If we're in the upper quartile of response, it will look nothing like today. So how do we think about those rapid changes in terms of these systems? And then finally, I wanted to say that there are efforts underway within the United States and around the world within health on conducting vulnerability and adaptation assessments within the context of iterative risk management. So these assessments are really trying to understand who's vulnerable, why they're vulnerable, where they're located, and thinking of ways to incorporate that with early warning systems. Early warning systems sit separate from these other processes. So we need to think about how to integrate into these other processes so that we can be a lot more effective. Which leads me back to my first point. We have all of this amazing environmental information. There's so much we could do to protect health now. And there hasn't been interest in the major funders for health to do that, which is really unfortunate, because we know from detection and attribution studies that people are suffering and dying right now from climate change. They're suffering and dying from extreme weather and climate events, and we have a real opportunity to make a difference in that. Again, my apologies for being so late.
Thank you. Thank you, Kristen. Please stick around for the panel. Okay. So you can sit up front. And so we're going to have a panel, too, for more discussion at the end of this. So I'd like to bring up Dr. Cira Ugarte, the Director of Emergency Health Services for the Pan American Health Organization, or PAHO. And
Good morning. Hello, good morning. Everybody okay? Thank you, Aubrey. Thank you, AGU, for inviting me. It is a privilege not only for me as a Director of Health Emergencies at PAHO, but also for WHO to share some of the progress that have been made, particularly in the Americas. And I'll discuss on the big issue of protecting public health from disasters, from theory to practice, where we began and how we are doing on that. When we see the images of emergencies and disasters and the health impact of those, of course we see daunting images and situations where we think that everything is going very bad and we need to respond quickly, and we easily forget that disasters are not natural. Disasters are the consequence of what is a bad development, particularly not considering what is the hazard. We usually hear many people saying that, for example, epidemics do not know borders, or disasters know no borders. Actually, disasters do know borders and do differentiate borders. The earthquake may not, the hurricane may not, and the disease may not, but the epidemics do, and the disasters do. And because of that, we've been moving towards how in the Americas evolving after each of the events and learning from those events, but actually learning, translating what we experienced into something different. And in '76, the ministers of health in the Americas saw that the problem was the coordination and the strengthening the capacity of the health services to respond to large emergencies and disasters, particularly volcanic eruptions, earthquakes, and floods, and they created a program to focus on preparedness. And then in '85, most of the hospitals that were well-trained collapsed, killing patients, killing health personnel, visitors, etc. So it was not enough to be prepared. We need to reduce the risk. So we began the vulnerability reduction in '85. The volcanic eruption in Colombia also showed that it is not only early alert, it's the decision-making process on how to communicate with the people. And guess what? We haven't learned that yet. We had an unfortunate issue regarding a volcanic eruption recently in Guatemala. And the process, even though it's been a challenge in court, still the discussion is around what do you do with the information that you have, and where you put in balance between what is the politics of it, the economic implication and the social implication of spreading the word. And that is not new. We are dealing with that every day today, in this country, in almost every country. And also the Hurricane Mitch showed many countries being destroyed, but not necessarily by the wind speed or force. It was the flooding. So those are the type of events that also show that the countries that have more capacity than others sometimes fail. And we need to look at what are the key aspects of that. And we looked also on pandemic influenza, everybody waiting for an avian flu coming from Asia and then beginning in our region. As you know, the virus is known as the California virus because it was here, but in Spanish flu, it was not from Spain. In this case, it may not have been from Mexico. And Haiti earthquake showed us that all the processes and the programs that we implemented over the decades were not working properly, and we're moving towards that. So, and the Zika epidemic is not a proper emergency, but it's related to climate change, but it's related with other things, and Zika came to stay. And it's staying very slowly, and it will resume in some years, and it will resume big time. And Hurricanes Irma and Maria in the Caribbean showed also great problem. And the countries in America have a strategic plan that is running from 2013 to 2018, by the end of this year, and the core of it is a more resilient health sector. So we're looking at how the countries themselves are taking the decisions to improve their capacity, but also to reduce the risk. And in theory, we can, every sector and in every country should be resilient to disasters. In practice, we cannot do that. We will never be able to do that. We have to concentrate in the services that are critical, that are the ones that have a big meaning in terms of the community. And we've seen that many hospitals, particularly health services and hospitals, have been affected by almost all emergencies. But we're also seeing that some of those impacts are related to the condition of the health facility and the location of the health facility, but also on the impact of the events. We know clearly, for example, that we cannot compare earthquakes. That is, in Chile, it's 8.0, and then another earthquake, 7-something, that's many times less than that, is causing more impact. Well, we know very clearly in geology and also in science of Earth that it is not the magnitude, it is the intensity, how the ground is shaking and how that affects the infrastructure. So we have hurricanes, other phenomena, and epidemics, etc., that are being affected. And in the health sector also, we've been working more than 20 years in reducing the vulnerability of health facilities since '85, since the earthquake in Mexico. And we discovered that we cannot cope with every hazard, and we cannot cope with all health facilities. It's impossible. We have to concentrate in those that will make a difference in terms of life-saving services. So in that regards, we focus on the hospitals. We've seen in the earthquake in the last report that we did was in the earthquakes in Haiti, Chile, and Japan that happened the same year, and we saw the differences. But in all of them, the health centers and health posts were overwhelmingly fully operational. And the problem was, particularly in hospitals, and when you lose a hospital, you cannot just easily replace the hospital. And there we have those hospitals, 67% of the nearly 18,000 hospitals in Latin America and the Caribbean are located in high-risk areas, and most of them are affected by earthquakes, and then by hurricanes and floods and other types of emergencies, leaving millions of people without health care for years. So the concept of safe hospitals came there, a health facility that will remain operational. For more than 20 years, we were looking at the safety of the health personnel and the patients, so the hospital should not collapse. For the general population, that's not enough. The hospital must remain operational, particularly for the most critical patients. So that is where we moved towards how can we assess, how can we see if the hospitals are able to operate in emergencies. So there was a tool that was developed by many experts from the US, from Chile, Ecuador, Colombia, Peru, Cuba, and many others. And we developed this tool that is Safe Hospitals Initiative, what is Safe Hospitals Checklist, so a series of topics to assessing a hospital, the mathematical model, the safety index calculator, and the hospital safety index. That index that was prepared by the countries was applied in thousands of hospitals, and the countries are now able to see which hospitals will operate based on the hazards that they have in the area. That's the main topic. The second one is the structural component. Will they resist? The other one is, will the equipment and the services, the utilities, the critical services will operate? And then the capacity of the organization of the hospital. So we have just an example, one of the countries, and when you put on top of that all the hazards, you see what is the probability of the hospital. We know now which hospitals will not operate in the next earthquake, for example, in Ecuador in certain locations, and which will operate. We won't be able to assess the hospitals during the disaster, during the earthquake, so quickly. That's importance because that allows us to send people to, for example, if we see a hospital that is in red and we don't have any other hospital around, we know that if something happens in this area, we need to send emergency medical teams with the surgical capacity, with the dialysis capacity. I mean, we need to send something because the hospital will not operate. We know that now. And that is a great advance. It's not just knowing what is the situation. And of course, we need to implement intervention measures, and 33 countries in the Americas are applying that. But it's not only in the countries that are applying those tools in the Americas. All of them are assessing their hospitals. Most of them are being assessed. Not all of them are being implemented. And we also categorize which ones to begin with. And we put the category C, that is 12% of the hospitals are urgent measures to protect the life of patients and hospital staff, because most probably these 12% of hospitals will collapse. So we need to implement those. In previous years, we were dealing with this, where to begin, how much money, and how to do that. And we have now a way forward, and most of the countries, more than 60% of these hospitals are being intervened as we speak. In some countries like Mexico, for example, the investment, for a country that is not all developed, by the investment, last year was above $2 billion in hospital retrofitting. So that's also a big advance, and many other countries, we are talking about hundreds of millions from a sector, that is health sector, that does not have all the money in the world, actually has less money than others. And then this initiative expanded to Europe. Many countries in Europe also are implementing the Hospital Safety Index. The Safe Hospitals Initiative is expanding also to Southeast Asia, because they do have their own issues, but they are applying exactly the same tools. And in the Eastern Mediterranean region also, adding an e-atlas for doing all those monitoring system. And also in Africa, and several, well, they deal with many other challenges, many other priorities, but still they are moving towards that. And the current situation in the Americas, 28 countries have included disaster risk reduction in their health disaster plans or programs. So they are implementing certain things, and they are the ones, the first and the ultimate responsible for protecting the public's health are the national authorities. It is not an international organization or an association or the civil society. It is the authorities who have to provide that. And the 34 countries are applying Hospital Safety Index. 25 countries have national safe hospitals, and you see all the processes. But we are still far from having all hospitals safe. So there is still a big challenge, and we're moving towards that, but it is difficult. But even if it is that difficult, climate change is here, and it's a reality. So we are moving. The new initiative is Smart Hospitals. An initiative has unique experience that links climate change and mitigation and climate change adaptation, and will be the new standard for disaster risk reduction in the world, as it is safe hospitals now. It will be in the health sector the new standard, the new gold standard of hospital resilience is smart hospitals. And we'll discuss what is the smart hospital. It's safe, so safe from disasters, but also green. And so we call them smart. And why? Because the hospitals and the health sector usually complains about the climate change and all the consequences of climate change on health sector. Actually, the health facilities are one of the biggest contributors to climate change, and we didn't know that, or we're not aware of that. When we meet with the ministers of health, we realize that, look, the carbon footprint, for example, of NHS and ENH in England, 25% of total public sector emissions. That's big. In Brazil, hospitals use more than 10% of the country's total commercial energy consumption. Wow. And in the US, the healthcare sector is the biggest, single largest user of chemicals. And there are many examples. So I just brought 3 of them, just to show that we also have a responsibility on climate change mitigation, not only adaptation. That's why we bring both, to have safe, to have smart, to have green, and then a sustainable hospital that is smart. And we say, where can we implement that? So we did smart hospitals in the Caribbean. You know, the Caribbean pays more than any other country for energy, more than any other country for water, because they don't have energy, they don't have clean water, they have to do several things, and still the hospitals use huge amounts of both. So to ensure that health facilities are disaster resilient, to reduce the impact of climate change, to reduce operational costs, to enhance user comfort and performance, and empower decision makers also. So we did that, and we are implementing that in seven countries in the America: Belize, Jamaica, Dominica, St. Lucia, St. Vincent and the Grenadines, and Grenada. And we're doing that right now. And the investment is quite low, and it's being done with some additional tools. We already have the Hospital Safety Index. We've prepared the green checklist for hospitals, baseline audit tool, the cost-effectiveness analysis, cost-benefit analysis, sustainable construction guide annex, and the smart hospitals policy for decision-making. And we had a meeting with the prime ministers of all the Caribbean countries a couple of weeks ago at the International Monetary Fund to discuss where the investment must go in terms of climate change. And they are convinced of that, but the decision has not been taken yet. And the conclusion was, okay, let's meet in March to decide where to invest in terms of climate change mitigation adaptation. So we completed one of the first projects, was in St. Vincent and the Grenadines. You see, 18 weeks, not more than that. What is the cost? Less than $400,000. It's not that expensive. And the thing is that the most, let's say, the biggest benefit that we have is that the community is involved. The community leaders are the owners of the hospital and the owners of that, and of course the health personnel and the authorities. Why? Because it has to be a common, let's say, benefit for all. And you saw that after a big storm that they had in St. Vincent and the Grenadines, in the island of St. Vincent, the only hospital that continued operating, guess what was? The Georgetown Hospital. All the other hospitals were not operating because it was a big storm, big flooding, etc. And not only continue operating, but they will provide water for the surrounding community, clean water, and they will provide energy also to charge cells and others to the community. Isn't that big? That's important. So we are moving towards that, and we have the support of the UK in this case, and all these countries are moving towards that. And we see that this Smart Hospitals project is being expanding. Now the countries in the Polynesia are interested in that. The Philippines and all the small island development states are putting that as a priority, because this is the unique project that is being implemented by those countries that do not have all the money in the world. But then we cannot be there only. So a new model on disaster risk management in hospitals is we have safe hospitals, and then we have a multi-hazard approach, because we need to do all the preparedness and response to every hazard, and then we have to implement the surge capacity, not only to respond inside the hospital, but also with higher demand, and the green hospital, and now we added, a couple of days ago, the inclusion of people with disabilities, people that have needs, the elderly, the children, the pregnant women, and the other people. And now we have that a safe, green, and inclusive hospital. That is very nice. And it is not a theory. It's being applied already in Chile, in Ecuador, and Mexico. And you know, the newest hospitals in Chile showed that they are not inclusive. They do not take into consideration the people with disabilities and certain things. So we monitor all the countries, yes we do, how the progress is being done by the member states, how can we implement the plan of action of disaster risk reduction 2016 and 21, and we're doing about the Sendai framework for action. What are the countries' status right now? And the last one, what is the summary on the 15 countries, how they are performing in several issues. Thank you so much.
I'd like to welcome our next speaker, Dr. Lori Peaks, who's a professor of sociology and director of the Natural Hazard Center at the University of Colorado in Boulder. And Dr. Peaks will speak about Converge, coordinated science, engineering, interdisciplinary extreme events research. Thank you.
Okay. Good morning, everyone. Thank you so much for joining us this morning, and a special thanks to Aubrey and the AGU for agreeing to sponsor this section and session. So as Aubrey said, my name is Lori Peak, and I am really excited to talk to you today about a new facility that we are starting at the University of Colorado Natural Hazard Center called Converge, as well as 2 associated platforms and networks called the Social Science Extreme Events Research Network and the Interdisciplinary Science and Engineering Extreme Events Research Network. And so we just heard an excellent presentation about infrastructure, and specifically about hospital infrastructure. And so I too am here to talk to you this morning about infrastructure, but I'm not going to be talking to you about physical infrastructure. Instead, I'm going to be talking to you about social infrastructure, here defined really as the networks and linkages and connections that bring research communities together, and that's what Converge is all about. And so Converge was recently funded by the National Science Foundation as part of their broader natural hazards engineering research infrastructure efforts for the nation to build community resilience. And there are really 3 big things that we're going to be working on through this facility. And so first is about linking the social science, engineering, and interdisciplinary research communities. Second, about developing and sharing best practices for the ethical conduct of research. And third, about enhancing as well as promoting social science, engineering, and interdisciplinary natural hazards work, as we've already heard this morning, to the end of trying to apply information to solve some of the world's toughest problems, which is what Convergence Science, as one of the National Science Foundation's 10 big ideas, as well as a big initiative through the National Academies, is all about. And so I think the example that we just heard from Ciro about the hospital safety index is the perfect example of what Convergence is all about. It's about thinking about a big problem, rising disaster losses, death in the context of disaster, and then bringing together a variety of disciplines. We couldn't have that hospital safety index if it weren't for the partnership of geologists, engineers, public health experts, epidemiologists, sociologists, and others. Through the National Science Foundation, what we're working to do initially is to bring together a variety of extreme events reconnaissance networks, including those that are being developed for the geotech, structural, nearshore, and social science communities. and also to link those extreme events research communities together in the context of disaster through this interdisciplinary work, and to National Science Foundation platforms, including the RAPID facility and the Design Safe facility that provides cyber infrastructure for the hazards and disaster community. Once linking those NSF platforms together, then also hoping to link more effectively to other platforms like DR2 that Aubrey leads. So those are words on a page. I would like to tell you a brief story about why I think this kind of convergence, networking across our research communities is so important. And this is revealed time and time and time again in disasters, and was recently revealed following the Indonesian earthquake and tsunami that devastated Sulawesi in September of this year. And so Nature ran this really fascinating article that was about engineers and scientists who were literally trapped at the border and were trying to get into Indonesia so they could do rapid reconnaissance research. But the Indonesian government has had a long-standing policy where you are not allowed to do research in the country unless you have a research visa. And so the Indonesian government reminded the scientists who were desperate to come and do their important rapid reconnaissance research that it was critical that they go through normal protocols to do this research, and also kindly reminded them that persons caught in Indonesia doing research without a visa are subject to up to 2 years of imprisonment. And so I think this story reminds us, right, of the promise and pitfalls of doing rapid reconnaissance research. Modern building codes and standards are a direct consequence of exactly that kind of important rapid reconnaissance research. But convergence is about thinking about how can we ensure that we do this in network and connected ways that are ethically grounded. So there are 5 big tasks that we're going to be working on through this facility. And so I'm going to share a little bit about each one of these tasks with you today. So the first task is about bringing together the National Science Foundation networks dedicated to this extreme events research and the NERI facilities meant to support that research through a leadership core group. Also, through this, to develop a research plan as well as best practice guidance of how we will come together to address important scientific questions at the interface of our respective disciplines. Also, to develop related data collection frameworks and guidance for data curation, publication, and sharing of the data that's collected in the immediate and longer-term aftermath of the disasters. And also to develop a strategy and research agenda for these groups, and also to assume a shared responsibility for communicating about with federal agencies, with the media, and with others regarding reconnaissance missions. And so we've already started developing some media communication strategies related to this for the research community. The second big task that we are working on, which was launched a year ago at the Natural Hazard Center, we actually started working on developing and building those social science and interdisciplinary science and engineering extreme events research networks. And so one of the things we're going to be doing over the next 5 years is continuing to build out those networks and platforms in order to better identify and then ultimately to help coordinate researchers in the event of a disaster. And so briefly, ICEER is about bringing together, again, ICEER is about bringing together engineers and social scientists who are interested in working together on interdisciplinary questions and also developing interdisciplinary methodological expertise grounded in the science of team science. And so the mission is, again, to connect across those different communities to encourage ethical and holistic research, and also to train and mentor a next generation of diverse scholars who are really interested in doing this kind of work. The Social Science Extreme Events Research Network is specifically for the social science community, and here, again, this is about identifying, connecting social scientists who are doing this work and also are interested in joining these teams, amplifying and advancing this work. And in order to move forward with the SSEER platform in July, we were all together in Colorado and we launched this invitation to join the Social Science Extreme Events Research Network with the intent of developing the first ever census of social science hazards and disaster researchers. 12 years ago, the National Academies published a big report on the state of social science in natural hazards research. And they dedicated an entire chapter to this question of the size, the composition, and the capacity of the social science hazards and disaster research workforce. And one of the things that that report revealed was that there's no agency, there's no group that's been responsible for collecting information on this particular research community. And without that information about the community, it's really hard to know whether the community is prepared to respond to these pressing 21st century challenges. So I'm excited to share with you today a few of the things we've learned through our SSEER census. And so some of the questions that we wanted to answer were in response to that 2006 National Academies report. We want to know how many social science hazards and disaster researchers are actually out there working in this field. Where are they located? So what's their spatial location? What disciplines do they represent? What disasters have they studied? Natural, technological, terrorist, or otherwise? And what is the demographic composition of the research workforce? And is the research workforce actually reflective of the people who we are studying and serving in diverse communities? And so as of October 30th, 2018, 618 social scientists have joined SSEER. And this is a map. This is not a complete census as of yet, but this is a map of where the people who have signed up for SSEER are located thus far, which is undoubtedly has to do with our reach and our networks initially, but we hope to continue to build this out so we have a more complete census. We are getting ready to launch this Esri map of the social science research community. And so when you go to the SSEER web app map, you're going to be able to search for social scientists by UN regions, and then also by the 24 subregions. And then also by nation, and as you can see, about 443 of the social scientists who have signed up so far are actually in the US. And when we invited social scientists to sign up as part of the survey, it's about a 7 to 10 minute survey that they completed, and we asked them a variety of questions about things including their disciplinary expertise, the methods that they use for data collection and analysis, the hazards and disaster they studied, their areas of expertise, and a number of other questions. And again, so the purpose of this is so that we can better characterize the community, but also hopefully facilitate more collaborative research. So when you go to this, you can search for specific researchers by their individualized research profiles. So if Ciro wanted to go in and find a public health expert who has studied hospitals in the context of earthquake disasters, he could go in and search for that. We're also hoping that in addition to having this census, that this will actually be usable during real time. And so we've already started experimenting with the census data and overlaying this with things like real-time weather forecasts, the Centers for Disease Control's Social Vulnerability Index, the US Geological Survey's hazards map, so that we can look at where researchers are in relation to hazards and so forth. Okay. That in addition to doing this for the second task, what we're also doing is we're developing a series of online training modules for researchers, and then are going to evaluate the use and impact of the modules. And so this just shows a series of modules and briefing sheets that we're going to conduct, because we know that a lot of times hazards and disaster researchers come into this field because their communities are struck low by disaster. And so that we're hoping that having these training modules up and online will help accelerate accelerate the training and education of new researchers into this area of study. The third task that we are completing through this Converge facility is we also have funding to help support rapid reconnaissance research for the social science as well as for interdisciplinary teams. And then we're going to be evaluating what the teams have learned, not just in terms of the science they've generated, but also in terms of how these teams are working together. And so we're building on this long-standing quick response research program that the Natural Hazard Center has funded for over 35 years. And so this fall alone, we've had a variety of special calls for proposals for the social science and interdisciplinary community in response to the hurricanes and the California wildfires. And why we think that having this census is really important in relation to these funding calls is we know that oftentimes when disasters happen, how teams come together are through our already established networks, as Aubrey already suggested this morning. But one of the things we know is that oftentimes emerging researchers who may not be affiliated with the major hazards and disaster centers may be left out of those opportunities to join reconnaissance teams. And so we're hoping by having this comprehensive geographic census that we're going to be able to hopefully further democratize the research and engagement process to ensure maximal engagement of the next generation of researchers. The fourth task that we are working on through Converge actually involves a partnership with a center that Aubrey has also helped to support. And this is the NERI Rapid facility that is at the University of Washington. And they actually are one of the facilities that have a variety of tools, technologies, and other supports that are available to researchers who are going out after disasters. And so we have a partnership with the Rapid facility and Joe Wortman at the University of Washington to extend mobile research applications that they've already begun to develop for the engineering communities, to also work with them to extend those mobile research and data collection applications for the social science community. And then the fifth task that we're working on also involves another partnership with one of the National Science Foundation engineering research infrastructure facilities, and that is Design Safe, which is at the University of Texas, Austin. And they have actually been developing out the cyber infrastructure for the hazards and disaster research community. And they've already developed several engineering data models where the natural hazards engineers have been publishing their data and have been using the cyber infrastructure to encourage collaborations. And so we're partnering with Design Safe right now so that we can actually accelerate the curation, storage, and publication of social science as well as interdisciplinary data, but also our protocols, our research instruments that we use in the context of hazards and disasters. So the next time a big event happens and somebody says, what do I want to do? I want to do a survey. You can actually go and you can find what validated instruments and scales and protocols are already available out there and have been used in other hazards and disaster contexts. And so this is just a picture of some of the social scientists partnering with the Design Safe experts who came to Boulder about a month ago, and we all drew out our research, how our research processes work. We talked about the instruments and the different data sets that we use and so forth, and then the Design Safe folks have gone back and they're beginning to actually build out these data models to allow us to publish our data as well. And so with that, I have 1 minute and 46 seconds left, and I will spend those to say thank you to all of you for listening, and thank you again for having us this morning. Thank you.
And that was just great. And really, we're building a community of practice. Dr. Nakayama, if you want to start coming up. So how do we bring our science across this community, like Dr. Peak was just saying, to the broad community, thinking about where you are and lowering the activation energy for people to participate, tools, resources, including the issues of ethical conduct of research in communities and IRB, and how do we really understand what communities need, but doing it smart and right and with communities and ethically, and making sure they are truly engaged in this process. I'd like to welcome Dr. Soji Nakayama, the Director of Exposure Dynamics and Research Section for the National Institute of Environmental Studies from Japan, and we've been working together for a number of years on issues including disaster research response. So thanks.
Yeah, that's okay. This one. Okay, I can do it. Right. All right, good morning. It's almost midnight in Japan. But thank you, Aubrey, and then AGU to bringing me up here. And then I'm very happy to introduce our efforts towards this disaster research response organization. And where's this one? Okay, all right. So, have you been to Ginza in Tokyo? Ginza is a street with the luxury shops. So we say that, so everybody comes to Ginza when they come to Tokyo. So we use Ginza as a street that everyone comes. So when we see Japan is a disaster Ginza, that means we have lots of earthquakes, lots of typhoons, flooding stuff. Indeed, 10% of world seismic energy is released near Japan, and 10% of world's volcano is located in Japan. So we're having about average more than 2,000 sensible earthquake per year. And then just after the 2011 Great Eastern Earthquake event, we had more than 10,000. And then in 2016, we just had the earthquake in Kumamoto that destroyed their castle like this. We had about 6,500 earthquakes, seismic activity, sensible earthquake per year. And we also had great levels of earthquakes. So for example, in 2016, we had about 10, that's a 9, 10, 8, 10 Mercalli level earthquakes. So, and then we're saying that it is highly likely to have, for us, magnitude 9 class earthquake in the next few decades. So we are preparing for that. And the other example is typhoon. This picture shows the aftermath of the typhoon in Osaka, which is a highly populated area. And then average more than 10 typhoons come just close to Japan every year. And then we are having increase in trends of violent rain, So it was about 250 times per 1,000 locations in 2017, which is a lot. So we're having disasters every year, and then we need to prepare for that. And this is a picture I have taken when I got assigned to this institute. Well, before I took my position in 2011, that was April 2011, I was working for US EPA for 6 years. And so I was doing exposure science, and I took this position to do national children's study, which is a completely different thing, to follow up 100,000 children, for 13 years, like a national children's study here, But I just got pulled out and then came to the conference and then said that we need the exposure science, scientists, we need a medical doctor to, well, by the way, I'm a medical doctor by training, but to come to the situation. And then so I went there, and then it was like this. And then like this, even that was almost 1.5 months, after the event. So, and then this is a town completely wiped out by the tsunami. And then flooding, this happened recently, I think it was about 2016. and then radiation event. So we need to do exposure assessment to do a better disaster research response in Japan. So we, National Institute for Environmental Studies under the Ministry of the Environment, we are the research body of the Ministry of the Environment, signed an MOU with the US NIEHS, thanks to Aubrey, to collaborate on disaster research response. We're mainly focusing on emergency exposure measurements and disaster epidemiology. And then alongside of that, Ministry of Health established Disaster Health Emergency Assistant Team, or DHEAT, that consists mainly of government health officials and assesses public health needs immediately after the disaster, and then provide governments with assistance for improving public health in a relatively short time period, like a 2 months, 3 months period. So we, as the Environment Institute, are focusing on the longer term response. And then disaster epidemiology needs prompt exposure assessment. But most situations do not allow epidemiologists and exposure scientists to prepare in advance. So we often need to rely on large-scale modeling for exposure assessment. So we need to combine geological scale modeling and epidemiology, so that we can do a rapid exposure assessment. So in this presentation, I'm going to present the case we did for the Fukushima event. So the goal of this research was to assess the very early phase respiratory exposure dose caused by the Fukushima event. And then, fortunately, milk and food consumption was suspended immediately after the incident because we had the experience of the Chernobyl. Thus, the main exposure route during the first 4 weeks was through respiration. But no model was available to estimate respiratory exposure dose for the first 4 weeks. So we first attempted to combine atmospheric dispersion model, or ATDM, and an exposure model. This was the first attempt we had for this kind of work. And then goal was to estimate thyroid equivalent dose during the first 4 weeks. So I'm just gonna introduce you the case report. So it's a complicated workflow, but in a nutshell, two different people from the people from two different worlds had to talk each other. So from the atmospheric, modelers, and then one from the exposure science. And we were talking in Japanese, but talking in a very, very different language. I think it happens in the English world too. And then, you can see we did sensitivity analysis, and then we assessed some uncertainty, but the language uncertainty itself is very different. So we asked, what's the uncertainty of your estimation in your atmospheric modeling? They said, well, if we have about 2 magnitude older, that's fine. And that's log 2, base 10. And that's too big for us to do the exposure assessment. We asked them, all right, we need a personal exposure. And then what they say, what does it mean? So what's the temporal and then spatial resolution of your model? So that kind of communication happened. So we had about a year or so communication and to actually start this work. It wasn't rapid at all. But anyway, that was the first attempt to combine atmospheric modeling data with the behavior and personal and exposure models. So we first validated atmospheric dispersion model using the actual measurements. And then And then we used that validated atmospheric model to calculate the iodine 131 dose in two ways. So we directly estimated iodine 131 deposition from the deposition, and then we indirectly estimated the iodine 131 exposure using iodine 131 per cesium 137 ratio. And then we took that result and then we put them into our exposure model to estimate the dose in each site with air dose measurements and then dose distribution in each municipality, because each municipality wants to see their exposures, and then dose by each evacuation patterns. Don't ask me about this because I'm not the atmospheric modeler, so they used those parameters. But I show you that. So their resolution is 3-kilometer mesh. And how many people are in that 3 kilometers? And how, we care about the people's movement, but they don't move too much, So many people fall into that 3-kilometer mesh. And so that was kind of the problem, But the model did good. As you see here, the dots are the real measurements, and then lines are the estimates from two different models, and they did pretty good. And then this is for the iodine 131, and you can see that we don't have that much measurement results, so it was very hard for us to validate the model, but it seems worked well. So we applied that to 3 different locations. One just very near to the Fukushima plant, and then the second one is south, and then the third one is on the north. So this is the result in a nutshell. So here's the observation on the left side, and then 2 different models. And then the last one is iodine 131 direct estimation based. So as you can see that on A and B side, the model has some overestimation. And on C, which is like this here, so you can see that on the north side, so the wind, how can I say, the wind direction was from north to south. So the plume went to south. So the north side was relatively less contaminated. So we had a good result with the model at that side, but not in the south side. So we had some overestimation, probably due to the atmospheric modeling part. So in addition to that, we developed some tool for the citizens who can look up on our website to estimate their own exposure. So unfortunately, those are all Japanese, but I partially translated. So this is the thyroid equivalent dose estimator that's on our website. And then it's a simple tool. If you want to estimate that dose by municipality, you just click this button, and then you can get this result. So this is, you can choose a city here. It's in Japanese, I'm sorry, but you can see the dose redistribution for this is 1 year old. So you can set the 1 year old, 10 year old, and then over 20 year old. So you can see your exposure, and then also you can estimate the dose by your behavior or by your evacuation patterns. So you can input your evacuation patterns, and then such day you were there, and then you can input them, and then this tool can estimate your thyroid exposure dose. And then that can export the graph, so you can see while you were here, you got this much. While you're here, you got this much. In total, you got this much. So this tool can be used by ordinary citizens as well as government officials. But say it was too late. So I hope that we can get this collaboration soon after, well before the disaster happens, so that we can do this kind of work very soon after the disaster happens. So we estimated sources of uncertainty. We have uncertainty related to the atmospheric models, like source term, uncertainty measurement data, and then other parameters we put into the atmospheric model. And as well as we have some uncertainties related to exposure models. So those exposure model parameters are taken from our ordinal situation. So indoor air dose ratio, behavioral data, pharmacokinetics. So we realized that we're lacking those kind of data too, not just only during a disaster, but also we need those kind of research during our ordinal time period. So, and then also we learned the lessons that we need the constant interaction with the geo side and the health side people, so that we can speak the common language in the disaster time. So the future direction, we're working on the integration of other exposure things. So, for example, other contaminants such as persistent organic pollutants, metals, and pesticides. So geoscientists, some of the geoscientists are working on this kind of thing. So we are trying to combine these chemical dynamics models with the exposure models. So we need to do a lot of work to combine those, because we're dealing with different temporal and spatial resolutions and stuff, and also we're working on different computer languages too. And then also we're trying to combine atmospheric pollution modeling, such as ozone and NOx and SOx and particulate matters. And then we're testing different kinds of atmospheric models, like dispersion models, inverse distance weighted interpolation model, as well as land use regression models. So it's on the way, and then I hope we can do this kind of collaboration better. And then I just hired 2 postdocs who's going to work on this data science. So I hope this gonna move forward very well. Thank you.
Thank you. While our next speaker is coming up, I wanted to just mention briefly, Soji talked about disaster research response. It's a program that we started at the National Institute of Environmental Health Sciences in partnership with the National Library of Medicine to create what's called the NIH Disaster Research Response Program. And it was really in response to a calling from leadership of the Department of Health and Human Services, CDC, and NIH, that we weren't responding quick enough to disasters. So we came together and said, what can we do to facilitate this? How can we get the tools and resources and some of that connective tissue built between us and processes and relationships? And how do we use our networks of researchers and grantees that we fund from NIH across the country and the world, CDC's groups, and others, and Japan has joined us, Health Canada has also joined us, and Dr. Peaks is talking about it, the network of social scientists. But it's not just to respond to the acute events, and we do have to get there fast and smart and effectively, but we also have to go and study groups and issues longer. Resiliency, long-term issues and concerns that we don't get. A lot of times we get there quick and we get some of the basic information, but we don't follow populations over time. Next, I'm going to introduce Dr. Jeff Plumley, who's Associate Director of Environmental Health at the USGS, and the importance of the USGS to generate data, but also the importance of his division to take that data and allow us to use it from the health sectors of the country to be able to understand that information and their response to disasters, but all the data that USGS collects and allows us to connect to that and use that information for our work and to better the communities. So, Dr. Plumley.
Thank you. So I'm going to take a little drink of water here so my voice doesn't go hoarse. So I'm honored and privileged to have been asked to give a presentation at this union session for Geohealth. And what I'd like to do is talk about something that I didn't really realize until I was listening to Dr. Peak talk, that USGS is a convergent science organization. We've known for a long time we do integrated, interdisciplinary science. In the last 20 years of my career, I've done what I would call transdisciplinary science, working with folks like Dr. Miller and Dr. Horwell and others across different disciplines looking at environmental health. But what I wanted to do today was give you a few examples of how USGS science that converges across natural hazards and environmental hazards is a good example and a good demonstration of why we need Geohealth and what Geohealth writ large can actually do to help society with disasters as one example. I want to acknowledge my colleague Dave Applegate, who is Associate Director for Natural Hazards. A lot of folks at AGU will recognize his name. And I also want to stress that we have, I represent a lot of different, in my talk, a lot of different work from many different people at the USGS. I've tried to acknowledge them where I can, but there are a lot that probably didn't have their names made the list. So, quick overview, USGS Natural Hazard Science. We do a lot of work in a lot of different areas, particularly on the geologic hazards. We basically do, we have the primary federal responsibility for assessments, alerts, and warnings. I wanted to make sure to get that in. That's wording specific from Dave. But you can see the geologic hazards, landslides, volcanic eruptions, earthquakes. We also do, across our other mission areas, floods, hurricanes, storm surge, all sorts of different activities on a lot of different disaster types. We also bring in geospatial characterization and geospatial data analysis as well. I represent what I call a stealth environmental hazards program that the USGS has had for decades. A lot of work we look at understanding the environmental contaminants and pathogens, including those that are produced by disasters, and what sort of hazards they might pose to the health of humans and other organisms. And one thing that we very clearly do, since we're a non-regulatory agency, we try to understand what are the actual concerns versus what are maybe some of the perceived. Following a disaster, you see a lot of headlines that tend to be very expressive in terms of potential issues, and a role for the USGS and science in general is helping understand what's an actual issue versus what's not. And we basically look at source, transport, fate, transmission, exposure pathways, and then for biological critters, fish, wildlife, insects, we actually have folks that measure toxicological and health effects, and then we collaborate with the health scientists from public health and medicine for looking at the human health effects. We've looked at a lot of different disasters. We actually have looked at floods. We worked on World Trade Center, the dusts, the Gulf oil spill, many different wildfires, volcanic eruptions, mine tailing spills, things like that. I'm going to use a few examples linking the natural hazards to the environmental hazards. The other thing that I wanted to mention while this slide is up, this takes an interdisciplinary team of geologists, geochemists, hydrologists, wildlife toxicologists, again working with human toxicologists, epidemiologists, folks like that. Also, one of the other roles that we find for disasters is that we need to understand the environmental baseline conditions and health baseline conditions. So we know the extent to which a particular disaster has moved the conditions away from that baseline. So going to jump into, the last year has been a very busy year from a hazards perspective. So I'm going to use a few key examples from the past year to show you the roles of convergent science at the USGS. So this is from the Volcano Hazards Program. The U.S. is one of the Earth's most volcanically active countries. And you can see we look at the hazards, we look at the threats. So what's the qualitative risk of a volcano to people, property, and national airspace? But then we also do exposure, and this is again where we're seeing the convergence between the hazards, the natural hazard scientists and the environmental hazard scientists. So how are people, property, and infrastructure affected by volcanic activity? So this is a pretty neat infographic for the report that you see down at the very bottom, the most recent update on the volcanic hazards across the U.S. So Kilauea, that's the first thing when you mention volcanoes right now in terms of 2018. The USGS has had a very extensive response. Our volcano hazards folks and others were running on red line for many months, and it was a great effort working with a lot of different collaborators, including Claire from remotely, Dr. Horwell, one of the co-conveners. And so across federal, state, local, private sector, and academia. This is on the Fissure 8 spatter cone along the Lower East Rift Zone. This has been a very damaging eruption. I think there were more than 600 houses that were taken out. And so it has actually been one of the more damaging volcanic eruptions in the United States in recent history. And of course, there were two very different eruption styles with collapse of the edifice up at the top, leading to these little ash eruptions, and then also the lava eruptions along the East Rift Zone, and the flowing of lava into the sea as well. And I'll talk a little bit about the different hazards those might pose from the health perspective. But first talk about the natural hazards response. So there were a lot of activities going on, collection and analysis of ash, of lava. The fellow on the upper right is doing gravimetry measurements to look for the presence of magma. The folks there are using a remote sensing device to detect sulfur dioxide, collecting lava. So this is the kind of activity the USGS is well known for. We've also brought together a lot of different advanced technology. So the one in the upper left, pulsed long-wave radar, can see through clouds and can be going at night. It shows scatter off the fresh lava, so you can actually map fresh lava. We've done very interesting lava flow prediction using supercomputing power that we've brought in to bear as well. And one of the things that all combined to do were these daily inundation maps that were very heavily used by the emergency responders. You see this area over here, and there's something blocking my way. It's vacation land. My family vacationed there right near a beautiful suite of a set of tidal pools, and we watched with dismay for all the people that lived there as their houses got covered and the tidal pools got covered. So it always is a very good remembrance that people are actually getting very strongly affected as we are working on these disasters. There was a lot of really interesting new roles for unmanned aerial systems doing these photogrammic surveys up top to help develop a three-dimensional model of the Hale-Mau-Mau crater and how that was collapsing. We actually used it for gas sampling, and it was very interesting. This made the news. We actually helped direct, our UAS people actually helped direct emergency responders to rescue a person who had been cut off by the lava flows. They were able to use thermal cameras to help detect where that person was. So what are the health concerns? Well, so volcanic ash particles with potentially biosoluble or soluble fluoride, metals, sulfur dioxide gas, which is an irritant at least, and in very high concentrations can have more profound effects. Volcanic fog, where it's basically a mix of particles of water with absorbed acid species and things like that, and lays, where the lava flows into the ocean as well, reacts with seawater to produce acidic droplets with a variety of other chemical characteristics. So the health response work was led by David Danby, who the USGS just hired, one of Claire's students, a couple of years ago to look specifically at volcanic ash. And they did a lot of work on the slide shows a lot of different things that they did in terms of gas work, and using UASs to monitor gas compositions. They did ash cloud monitoring to look at how the ash clouds might affect folks downwind. They looked at leaching of soluble constituents from the volcanic ash. So there was a wide range of things that basically informed the local effort in terms of what are the environmental health implications of the different eruptive products like the ash, the gases, the lays, and the VOG. And that we hosted multi-agency health-focused community meetings and basically worked a lot to keep people informed locally. I wanted to transition to wildfires. We all saw the devastating wildfires that just hit. This is the second year in a row where California has seen very devastating wildfires late in the fall. The Camp Fire and as you can see on the north in the MODIS image, and the Hill and Woolsey fires near Malibu. USGS has a lot of capabilities geospatially. The GeoMac, for those of you that don't know about GeoMac, that is the first place I go when I hear a fire has started, because they show burn perimeters on a daily, if not more regular basis. So you can actually plot the spread and see where the fires are occurring. We also have Landsat that USGS runs that will provide a lot of information about distribution of burned areas and vegetation impacts and things like that. One of the key things that the USGS is very well known for, and this has been a recent development in the last, I guess, decade, is the rapid development of these post-fire debris flow hazards assessments. And you see this for the Camp Fire on the upper left and the Woolsey Fire on the lower right. Basically, it's little sub-basin based, so the red sub-basins are those that, based on the topography and the burn severity, are likely to release. This is very heavily used by folks, and this is particularly important to get this information out soon because, as you saw with the Camp Fire, the rains came within a week of following and the Woolsey, they came within a week following the fires. So being able to understand where the debris flows, what drainage basins might be affected. Concerns about the environmental health hazards. That's something that the group I worked on before I stepped into a management role. The group I worked with, we did quite a bit of work. There are concerns about the wildland firefighters, the burned area rehabilitation team on the upper right, and then people going back in and sorting through the debris of their houses. How many newspaper articles I've seen where people go on wearing shorts and a t-shirt and no respirator. My colleague Todd Hafen in the lower right, you can see down here, when we get ready to sample, is wearing very full PPE with a high-quality respirator. So what are the concerns? Well, the vegetation ash, you see all the white there, that's the most heavily combusted ash. That actually has high levels of sodium hydroxide, potassium hydroxide, things like that. It's very light and fluffy. Those create caustic alkalinity when they come into contact with the moisture in your eyes and your upper respiratory tract and can cause problems. The black ash is less heavily combusted. It can have a variety of things like polycyclic aromatic hydrocarbons, things like that. Ash and debris from burned buildings, basically that can have a lot more stuff in it. We've found hexavalent chromium. We've found, again, these caustic alkali hydroxides. And we can actually tell the age of the houses based on whether or not they have asbestos or high lead levels in them as well. Airfall ash deposits during an active fire can actually pick up, the fires can actually pick up these things and carry them downwind, and people are exposed to them downwind. So we've started looking at how we can do more work characterizing the smoke from active fires. There are a lot of people that are looking at smoke, but they typically look at the organic and the soot particles. There's actually, we've done work on prescribed burns with these multi-copters where we actually are collecting air samples, and we can actually see a lot of soil particles and some metals and things that are there. We've looked at post-fire impacts on water quality. Dilution happens that seems to be fortunate for diluting a lot of the things like the alkalinity that would be generated by the white ash. But there are other parameters that need to be looked at as well. And our Southern California, San Diego Water Science Center has a very nice website. And a colleague, Carmen Burton, just had a paper fairly recently on water quality impacts. The Anchorage, Alaska earthquake just happened. The shake map that you see on the left, that comes out within minutes and is then modified over the course of the day. That's very heavily used. We have folks that are working on helping assess the damage and trying to understand the damage such as liquefaction and landslides and things like that in the geologic and geophysical context of earthquakes. There was also a very interesting, Anchorage had a 20-story building that was heavily instrumented by the USGS back in the early 2000s for shaking. That building was damaged, but we had sensors on a lot of different floors that are going to provide a lot of spectacular information for how buildings move during an earthquake. So that was sort of the long game. 14 years later, those sensors are now playing an important role. We also had work with the VA where we instrumented the VA Medical Center in Anchorage as well, and we were able to show them very quickly that the damage was probably, and shaking was not that substantial. USGS has done a lot of scenarios, well known for that, and I had the privilege back in 2008 of starting to work with Lucy Jones and Dale Cox and Ann Wine and a bunch of other folks on the tail end of the shakeout earthquake scenario. The most recent one is Haywired, which is a magnitude 7 earthquake modeled along the Hayward Fault, basically along the eastern part of San Francisco Bay. You can see the modeled shake map. These scenarios are, in my view, a spectacular example of convergent science, and where Lucy and Ann and others have brought together the earthquake scientists, the engineers, the social scientists, and all sorts of different folks to look at what can we do to better predict and therefore allow better planning, resilience, mitigation, things like that. So this could actually be a pretty substantial earthquake. 400K people could be displaced, a lot of people needing rescuing from buildings. And Charlie Scawthorne worked to assess the fire risk, and due to ignitions from electrical lines and gas, could trigger urban firestorms that could destroy anywhere from tens to hundreds of city blocks. So this could be a really substantial event. So what we do, starting in 2008 on the different disaster scenarios, the environmental health hazard folks, me and my colleagues, start looking at different layers that build upon the data layers generated by the seismologists, by the engineers and others. We can look at census tracts, so basically on the upper left, the darker the color, the greater the number of buildings that were built prior to 1980, meaning they have higher levels of lead and asbestos. We can look at sources of potential chemicals, like if you look at the middle plot here, it looks like there are a lot of facilities that store anhydrous ammonia that are in the zone of most intense shaking. And then there are wastewater treatment plants, things like that, and then the fire ignition. So we can put all that together, and we can basically say what are the plausible environmental contamination concerns. And I still haven't figured out yet how to do a cool infographic that gets away from all these words, but basically, potential releases of anhydrous ammonia in the zones of highest shaking might be one thing. There are other more localized releases of sulfur dioxide, hydrogen chloride that are stored there. There are a variety of liquid chemical storage areas, and then smoke at the direct fire. I think one of the biggest potential impacts are the firestorms, and those will generate not only, so the regular analysis examined the potential impact for building collapse, things like that. The urban firestorms combined with the dust from the collapse, I think actually would be one of the biggest health hazards. Well, there will be a lot of increases of heart attack, stroke, and asthma due to stress on the respiratory and cardiovascular system. And that, I think, would probably be one of the biggest things that the local public health people would have to look at. The longer term, there are potential exposures to various contaminants, but those are not necessarily well studied. Again, a reason why we need to be working with the public health people. So here's the summary, and we basically like to say that we support the economic well-being, safety, and health of the nation's communities. And we do transdisciplinary convergent science, and it basically provides a good lesson for why we need Geohealth and different communities working together going forward. So, thank you.
Thank you. And I'm going to invite our panelists, our discussants up here to join us for a discussion here so we can open up the floor for questions, and for those people that are joining us remotely as well, we're going to engage you. And as folks are coming up here, what we've talked about today is it takes a village. And it does in so many ways here of our scientific community, broadly speaking, to come together. And I think communities don't understand that the collection of this data and information just happens. It doesn't just happen. And we really need to come together to empower this, to actually get it done, and to be able to get the information that helps us prepare, as Jeff said, helps us respond, and helps us recover from these situations over the long term. And I think we'll sneak and get everybody in here. You know, and as Cyril mentioned, understanding our infrastructure. How do we understand our infrastructure and allow that to then translate into situations? As Dr. Ebai mentioned, you know, looking at issues in climate change and what do we understand about our changing environment and how do we apply that information and then speak to our communities. It's this translation of information together back to communities to allow us to act and improve our resiliency. So I'm going to put out the first question to my colleagues here on the panel. I want to thank everybody for their fine presentations. But thinking about converging science, and I guess we can start it on the outside with Jeff, how do we come together looking forward to continue to foster this capacity to build and respond to these types of situations, both emergencies like we talked about, but also the emerging threats that are coming our way?
I think that's a really interesting question. I liken what we're doing to a snowball rolling down the hill. We have to start by packing the snowball, and then as we start rolling it, it actually will gain volume and mass. And so that's where things like Geohealth can really help bringing. I was delighted to see in all the Geohealth sessions that have been held so far that there are a lot of people that haven't necessarily come to AGU from the public health community. So this was a nucleus or a tiny snowball that AGU has really helped do. Also, the dynamic leadership of Dr. Miller, who has an evangelist to his public health colleagues in terms of why transdisciplinary science linking earth, engineering, health sciences is so valuable. The work that Dr. Horwell has done for decades on volcanic health-related aspects of volcanic ash. So these are all efforts that we just need to keep going on, doing communication. One of my colleagues up here mentioned the language. That's been one of the experiences that we've had, is that I can be talking about something and I use a term and it means a completely different thing, hopefully not insulting to the colleagues from across the other disciplines. So we each need to understand our terms, we need to understand our acronyms and get definition of acronyms, things like that.
Cyril, you want to?
I think it's not that easy to bring together people from different disciplines. It happens inside each institution that each one has its own responsibilities and have to deliver on their work. It's not that easy. But still, I think when we put the people and the communities at the center, everything fits together. When the development, for example, of the Hospital Safety Index, the discussion that we had with the structural engineers, with architects, with high level of health planners, is the engineers would say, in order to see if the hospital will not collapse, I need to do X and X studies, even microtrepidation and computer science, et cetera, even samples from the structure. Said, wait a minute. If the earthquake strikes that community and the people are outside the hospital because they are fearing of the hospital collapse, you cannot wait 2 months to respond to that director of the hospital. What is that you see in the structure that you can say that the hospital will not collapse or is safer to enter? So those are the type of things that are not in science exactly, but it's coming to what is the broad experience and the lessons learned and the science put at the service of the people. Mm-hmm. And I think when we put that at the center, everything fits perfectly.
So thank you so much for the question. And I think this question about how do we come together is crucially important because it is a process question. As we've heard throughout this session, that process is difficult. It takes a lot of time. It takes a lot of institutional support. But I think maybe the first question we have to ask is why do we come together? And how can our science be enhanced if we are setting these agendas in advance, if we're thinking about what are the most crucial and pressing scientific questions, as well as what are the most pressing and crucial humanitarian questions. And I think when we center our why, that's what's going to allow us to advance our science, because often those really critical convergence questions, they don't get asked after the disaster strikes. It takes so long to form those questions together that I think starting with our why and then working on our how is what's going to move us forward. Thank you.
So I think the tabletop exercises is also important for this kind of activity. You know, the Albridge teams are doing, gathering the government officials and university researchers and local community people to prepare for the future disasters. But we as a scientists do not do that kind of thing often. So we just come to the conference and we present our own work and then ask some questions. And then also we do just our own, science and our own, interest. But if we come together and do this kind of, exercise, for example, just assume that some nuclear facility just, blow up, or we have such and such, wildfires, what we can do, as a scientist, and then we can probably find out some data gaps and, research gaps in that, and then we can just go into our own field and fill that gaps. So that kind of activity, I think, is important for us to do to deal with their actual situation.
One of those lights are bright.
Yeah, that's right.
There's a lot of stuff here. I'll add a bit of a top-down perspective on what's been learned in addressing some other issues. There are centers of excellence, basically, now being established by several federal agencies around climate variability and change that bring together local stakeholders, bring together academia, decision makers, and representatives from these different agencies. Some, like the NOAA-RISA, the Regional Integrated Science for Assessment, have been going for 20 years. And these are really highly effective. And it does require a sustained commitment from the federal agencies in ensuring that you do have the range of partners. It's great to hear the strong interest in having Geohealth now part of these discussions. And it does mean that there does have to be this top-down commitment to make it happen. Mm-hmm. That the funding for these kinds of efforts from the traditional funders of population health research are frankly uninterested in this topic. And so trying to get funding to work in this area is incredibly problematic. And so I really welcome the comments that we heard today and hope that as we go forward, we'll see more efforts to try and ensure that the tent includes the whole range of issues that need to be addressed to help protect the health of the citizens in the communities we're concerned about.
And I'm going to ask the first question of Chris, actually. So this is from one of our remote persons, and it really goes to your conversation about changing patterns of climate and heat, and the importance of changing human behavior, and how do we have people understand what we're putting forward and actually make positive and actionable changes for themselves and their community.
Well, first I have to smile because I was remote initially, just because I was in the wrong room. Sorry about that. It's an incredibly good question for which we really don't have an answer. There's almost no research investment in understanding how to do that. That, as I mentioned before, there's lots of investments in setting thresholds, but not really good investments in understanding why people make the choices they do, not only during heat waves, but during any kind of disaster. I've lived and worked multiple times in Europe. There's always flooding events in Europe, and there's always at least one runner who says, I go out and run every afternoon at 3, and I'm running every afternoon at 3, even though there's a flooding event going on, and gets into harm's way, right? How do you communicate to people that changes need to be made? To whom do you communicate that information? Is it the individual themselves? We know children are a particular risk. Children die in cars every year in the United States because of heat. An appalling number die that way. Parents don't quite understand what is it that we're not saying that will really help people understand that a car can go from being warm to excessively hot in just a matter of minutes. So again, we need those kinds of research, we need that kind of investment so that we can come back and learn lessons. And one plea I have from doing lots of assessment work is we have case studies, not in this area, but in lots of areas, we've got lots of case studies. And unfortunately, most of our case studies, when someone goes out and takes a look at this, are not designed to explicitly capture what is unique about this situation and what is general enough that you can transfer to another situation. So people will go out and study a particular disaster, come back, say this is what we learned, but they don't say there was some political context, there was some geographic context, there was something that you can't transfer from one place to another. So how do we think about what's transferable so that we can start scaling up these lessons much more rapidly than we're doing now?
I want to invite people in the room. If you have a question, please go to the microphone over there to ask that. That would be great. And sorry, I didn't notify you.
Bob first.
Oh, can I go ahead?
Yeah, go ahead.
Bob Chen, also from Columbia University. I just wanted to ask a question about data issues. Of course, I'm from the informatics track and work in the data field. So a lot of issues about integrating data between different fields were mentioned. I only heard hints of anybody really thinking strategically about data. You know, bluntly, NSF is usually not very good at data management and stewardship. The other agencies are better, but you know, where do you see attention to integrating across, you know, household personally identifiable information with other types of information? That's always a problem across the medical to larger public health and environmental data. Where can that happen in a better way to support the kind of research you're talking about and applications that you're talking about?
Thanks, Bob. That was a great question. And I'll back up for a second that we're looking at risks, and risks are a combination of a hazard, an exposure, and then the vulnerability to that exposure. Right. There's lots of data on hazards. There are good data on exposure in terms of location. Coastal zones, for example. It's not as good as we've got for the hazard information, but it's better information. The really big gap is the vulnerability. We have very poor data on understanding where people are who are vulnerable and how to locate those people. So there has been just historically a very limited effort in trying to have any sets of data that will provide critical information for understanding where interventions are effective. We have projections there's going to be a flood. Do we actually know who in the flood zone is most at risk? Not really. And so our interventions are fairly generic and are not as effective as they could be. And I think there's lots of discussion of having a much bigger push on that piece. And when we have that piece, we'll have more data that can be integrated so we can be much more effective in preparation, response, and recovery.
Anybody else want to comment?
Well, my experience, it took us most was to integrate data from different parts of the institution and government. You know, they use different data formats, so that cost us much. So we started one agency dedicated to gather all kinds of those kind of disaster data and then put them into the one format so that everybody can use. And then also they're showing us some data format that we can bring it to the field and then fill it up so that we don't have to care about the different data formats. So that's starting, but that's very important, I think.
And I just quickly was going to say thank you for the question, Bob. And I think that one of the things in order to integrate data, we first have to make data available, as you have dedicated so much time and thought to how do we do that. And I think that's one of the things with this partnership with the NERI Design Safe and thinking about how do we incentivize researchers to get them to share their data, because we know there are a lot of disincentives for us to actually share our data. And so that's why we hope through assigning DOIs and making the data sets publishable and so forth, that's going to hopefully help to incentivize both publishing the data, but also, again, publishing the protocols, the instruments, and so forth, so we can understand how the data were made. Thank you.
Probably just a quick comment on translating the data and the research into practical recommendations for the public and the communities that have to take action and the decision makers. It is not that easy, but we need to move on that.
One quick thing, the USGS is very clearly recognizing the need for big data, and we generate national scale data sets, some global scale data sets, but there's always the key of how we make it more accessible and usable. One of the really valuable experiences I had as a research scientist a few years ago was when the USGS Powell Center was put together. That's a specific center designed to bring together big data sets from different disciplines and have experts work together on how they can interpret them. And Aubrey proposed one on linking geologic data on asbestos occurrence across the U.S. with epidemiological data, and that was participating in that was really a good experience for me. That was seeing just how different colleagues work across different disciplines and how they interpret and how can we meet those challenges of not only making the data accessible, but also how do we make them interoperable and comparable and statistically look for statistical correlations, things like that.
I want to put some questions out there real quickly. We're not going to be able to address them formally, but just to let folks know. So on the line, there were questions about some of the environmental approaches that you use, Soji, in terms of the responses in Japan and interest in modeling and what we do with that, as well as for you, Ciro, some interest with regards to understanding not only that infrastructure, but trying to get to build standards that communities can use, but also being cognizant of the fact that those standards may be corrupted in some ways and not applied well in some countries or in some locations because of a lack of true appreciation or support for those. And I want folks just to ask your questions quickly, and then we're going to have to wrap up here, but I want to put these questions out there so we can all think about them as we go forward. Why don't you ask your question real quickly?
Okay, really quickly, a question that I assume some of the panelists are struggling with as well. I looked up deaths from earthquakes over the past decade, and it's on the order of 50,000 per year. Contrast that with, say, 5 million people per year, preventable deaths dying from airborne pollution. How do you balance the effort? Should we all become air pollution scientists? Probably not. But how do you balance these, your own time, and where do you think the funding of research on these issues should be?
Thank you. Ramesh, your question?
Based on the presentation, to five panelists, I would like to ask, we talked about the buildings, hospital, and I would like that the government and the cities must follow the building codes for the hospitals, okay, so that the hospital should remain intact, just like airports, okay. Because in developing countries, there are a deal under the table, you see, and the people, they do not follow the building codes. Okay, so that we should do, and also the school buildings. Okay, and the other thing is, I would like whatever we talked about the radiation, okay, dispersion. The city should display the wind pattern, because if the wind pattern is displayed, people, they will know that where we are, what we are going to get in the 10-kilometer radius of the cities. Okay, and also during the summertime, during winter time, due to climate change, people are suffering. I have a mother of 85 years old in India, and I call her every time.
I hate to interrupt, Ramesh, but we're going to have to just let the last quick question, and then we'll continue the discussion. And
Okay.
for folks that are watching and others, we will continue this discourse. We wanted to get this session out here today for folks to continue.
Okay.
So maybe just put your last quick question to the person behind you very quickly, and then we'll continue up here after.
Let me
Yep.
complete.
Okay,
Because
please.
the old people, they would like to protect themselves during summertime, during winter time. So we should do something.
Thank you. And the last quick question, just to have it hanging out here for us to think about.
Hi, this is Mengling Jing from University of Maryland College Park. I'm wondering if our AGU or US and the federal government could serve as a union to suggest the industry to share some information. For example, one of our application research is to need to know the driving pattern. And I understand that those cell phone companies, they have those data, but due to the privacy protection policy, they cannot share us this data. I'm wondering if you, altogether as a union, we can suggest some policy or standard, they release us some data will have the privacy protection for those users. Hopefully we can move forward to share this data with our research.
Great.
Thank you.
Thank you. I want to thank everybody on the presenters today. Let's give them a round of applause. And thank you for attending this session, and we'll continue the discourse. If folks want to meet with our discussants, please come up here, and we'll look forward to engaging on this important topic going forward. Also to my colleague here, Claire Horwell, who helped keep this all running behind the scenes, and thank you, Claire, for all your activities.
Just to say, I've been live tweeting throughout the session, so if you are on Twitter, find me on there, and then you'll be able to catch up with everything we've been doing if you haven't been here for the whole session. Thank you.
We get it, figured.